one thing that's come into, I like the word used, limelight, is that we are now using a lot more next generation sequencing. 10 years ago, we didn't hardly do that at all. 5 years ago, we started, and then now for almost all tumors, we're measuring next generation sequencing. So, Dr. Liu, do you use next generation sequencing for somatic disease? And then also, when are you referring for genetic testing?
Yeah, so I think that's a great question. I think as a urologist, anyone that comes in with any form of metastatic prostate cancer should get genetic testing. And there's lots of ways to do this. Obviously, genetic counselors are a really great resource. And from what it sounds like, there aren't as many as we need, to go around. They're very busy with all the new genomic tests and studies that are coming out. So certainly there are some certain tests that we can run in clinic, like we use Tempus, for example. I mean, there are some other genomic studies that we can, start with, but I do recommend sending people to genetic counseling, looking for some of these, homologous recombination, mutations, DNA repair mutations, tumor mutations, MSI, BRCA, things like that, because they really do personalize and inform treatment options. Yeah.
And speaking of that, there are some things that have come up in recent papers that kind of can predict who's going to respond better to certain therapies. Dr. Satpute, can you walk us through like SPOP mutations and RB1 and TP53 mutations?
Yeah, so I guess if you want to think about these, SPOP kind of sits on one side, and then the P53 type, these more aggressive types, kind of sit on the other side. That kind of tells us how that person's disease is going to behave. That's one, and also how they're going to respond to the androgen deprivation type of treatments. So SPOP is one of the favorable markers. Yeah. So if you find that mutation, it is likely, for one, the Gleason grade tends to be lower in general, and also they tend to have an indolent disease, and more importantly, they tend to respond to the hormonal manipulations better, deeper, and even longer. So that's an important marker that I think is going to be used more and more in the future. Now, if you're talking about the other ones, the TP53 type, and we know it from other cancer types too, that these type of cancers tend to be very, very aggressive and tend not to respond to a lot of our usual treatments. So I think that helps us kind of tilt our treatment decisions toward one way or the other. Like, for example, if you have a TP53, you would think maybe they should get a triplet therapy as opposed to doublet.
Yeah, and that's what I was thinking as well. All that's recent within the last several years. We've been seeing reports of that. So, you mentioned the triplet trials, ARASENS and PEACE-1, and Dr. Satpute and I are on the treating end with docetaxel, but you all are on the referring end for that. And so, I wanted to sort of see, Dr. Liu, how do you think through? You see a patient, and then you're going to refer to medical oncology for docetaxel. What are the sort of things that you're going to tell the patient, and what's the major benefit that we're going to get out of triplet therapy?
Absolutely. I mean, you brought up the ARASENS trial. Showed that triplet therapy has improved overall survival over doublet therapy, but I think that the effect of this is more pronounced in people that have high volume disease. I think when it comes to low volume disease, maybe about equivalent or did not statistically show an increased benefit for overall survival. So when we are reviewing all the scans and we're talking to patients, I think we can always, even if we're not the ones prescribing, kind of give them a heads up. Hey, the medical oncologist may want to do some, chemo and some other kinds of drugs. Maybe talk a little bit about some of the, toxicities. Everyone wants to know when they hear the word chemo, like what that means, right? But I think just priming patients for what they're, might hear in your office.
Yeah, gotcha. And then with regard to, the ARASENS trial, if you could walk us through, Dr. Satpute, about ARASENS and the fact that it did not have a control arm with ADT and DARA alone. It only had, the control arm was chemo and ADT.
Yeah.
And how do we reconcile that?
Yeah, so as you know, the story starts with CHARTED trial, and that is when chemotherapy was introduced in early stage of metastatic prostate cancer in a hormone-sensitive setting. And there it clearly showed that adding chemotherapy really improves the patient's overall survival in addition to the ADT. Now at the time, it was just ADT and chemo, and there was not the third component, which is what was tested in these two trials, the Arasens and Peace One trial. The problem is now with all the doublet trials, we know that doublet is an essential component of treatment for metastatic prostate cancer in hormone-sensitive setting. So then the question really is whether chemotherapy adds the benefit in a particular patient or not. And unfortunately, neither of these trials could answer that question in a straight manner because their control arm was not without chemotherapy. But we still use some of the data we extrapolate from CHARTED and some of the sort of like the real life data that we think points us toward maybe using the triplet therapy in very like specific type of or certain type of people where there is high volume disease and certain high risk features that we've just talked about. And unfortunately, these trials don't really say that, but we still have that data as our only data to go after it when it comes to triplet treatments.
Yeah. I guess the way I like to think of it is that when a man has castrate-sensitive metastatic disease, everybody gets ADT in a doublet. I mean, and an ARPI. I mean, it's very rare that you would have a man who's not going to be on an ARPI. It might be the older man, but he's 90 plus, who just he's not going to even tolerate the pills, and then he's going to get adequate palliation from ADT alone. But then the next question is, who is a candidate for chemotherapy? And that's going to be the high volume. It's going to be your younger, fitter men, and a man in whom you look at the disease and you think, wow, that's really aggressive disease. That man needs more than just ADT and an ARPI. But there's issues about giving chemotherapy and the whole de novo thing. So for I was going to ask you, does de novo metastasis, which is synchronous metastasis versus metachronous metastasis, does that make a difference when you're thinking this through?
I think in some way, yes. So I'm usually more aggressive or push the patients to get chemotherapy sooner in the de novo diagnosis. If the patient has had treatment to the primary prostate cancer and then develops a metastasis, we tend to delay the chemotherapy somewhat into a later stage of their disease progression. Seems to be a different disease biology, I believe.
Yeah, gotcha. And then one of the things that comes up on our end is about the timing of chemotherapy. So many times, our urology colleagues will diagnose the metastatic disease, start the ADT, even start the ARPI therapy, and then we'll see the patient at some point, and sometimes it can be weeks later, maybe even a month or two later. And some of the trials have been very strict on, like I think Arasens was 6 weeks from the start of ADT, and then Peace One was about 3 months from the start of ADT. But I don't really have a feeling like you have to start the chemo quickly. And have you ever seen a man in whom you really wanted to give, Dr. Bhanji, I'll direct this to you, ADT and ARPI first, and then kind of see how it goes and whether you could add the Taxotere later?
Yeah, again, in my limited experience, we come across that scenario every once in a while, and that's where it's really important to, one, understand, the patient's goals and kind of what kind of toxicity they're willing to kind of tolerate. And then kind of understand, what their progression has been like, taking into account things like PSA doubling time. If you have any sort of genomic classifier data from their, previously, I think all of that information can kind of help inform how aggressively you want to push them to additional therapy.